Good afternoon, folks. Let me welcome you to the Senate Health Policy Committee. And with that, I'd like to ask the clerk to please call the roll.
Chairman Marlowe.
Here.
Senator Robertson.
Here.
Senator Emmons. Senator Hune. Here. Senator Jones. Here. Senator Shoemaker. Senator Warren. Here. Senator Johnson. Senator Ananick. Here. Mr. Chair, there are 6 members present. You have a quorum.
Thank you. Moving on. Senator Warren moves to adopt the minutes from the April 30th, 2014 committee meeting. With no objections, the minutes have been adopted. And Senator Jones moves to adopt the April 24th meeting 2014, and without no objections, the minutes are adopted. Thank you, both senators. At this time, I'd like to excuse all absent members, and with no objection, all absent members are excused. Thank you. At this time, I would like to invite Dr. Cauldron to come up and give his presentation on a census of the state healthcare transparency website. Doctor, come join us. Make sure your light is red. That there's a little red square up there. Make sure it's bright. And whenever you're ready. And I'm also, thank you, clerk. He even put it in big writing and I missed it. I want to remind everyone that we are being televised today. Thank you.
Good afternoon, and thank you, members of the Senate Health Policy Committee. My name is Jeff Colgren. I'm an assistant professor at the University of Michigan in the Department of Internal Medicine and a member of the university's Institute for Healthcare Policy and Innovation, as well as a research scientist at the VA Ann Arbor Healthcare System. I'm addressing you today as a practicing internist and a health services researcher who studies how to help patients make better decisions about their health and healthcare. My views are my own and do not reflect the policy or position of the University of Michigan or the U.S. Department of Veterans Affairs. Mr. Chairman, as you know, healthcare costs are continuing to rise. And with increasing cost sharing, patients are spending more of their own money on healthcare services. Unlike virtually any other sector in our economy, these patients are being asked to buy a product without knowing how much it will cost or what they will be getting for their money. For many patients, this leads them to have great financial burdens or even go without healthcare services they need. A common sense, market-oriented solution to this problem is to make healthcare prices more transparent. Such transparency could help patients find the most affordable places to receive recommended healthcare. It might also eventually narrow the range and lower the level of healthcare prices they face. Most importantly, when patients have access to information about the prices and quality of healthcare services, they will be in a better position than ever before to make the healthcare decisions that are best for them and their families. A growing number of stakeholders are realizing that such healthcare price transparency is not only long overdue but also attainable. For example, many health plans, consumer and third-party organizations, and state governmental and non-governmental organizations are now reporting healthcare prices to patients. Within this landscape, state governmental agencies are perhaps best positioned because they can collect and report comprehensive price information under legislative or regulatory authority. In contrast, price information reported by health plans is often not comprehensive within a market, and access is generally restricted to plan enrollees. Similarly, price information reported by third parties is also often restricted access or reports information that can be less valid or reliable. In order for these organizations to help patients make good healthcare decisions, the price information they report should be relevant and accurate. First, prices are most relevant for services that are predictable, non-urgent, and subject to patient out-of-pocket expenditures. For example, for patients with diabetes, there is a well-defined set of routine services that virtually all patients will need every year. For example, laboratory testing, blood pressure measurement, and an eye exam. For a diabetic patient in a high-deductible health plan who will have to pay for these services out of her own pocket because they are not defined as preventive services, information about the prices of these predictable, non-urgent services would be highly relevant. In contrast, prices for healthcare that is unpredictable, non-urgent, or not fully subject to out-of-pocket expenditures would be much less relevant. For example, no patient knows when she will have a heart attack, and I would hope that we would all agree that shopping for healthcare in the middle of such an unplanned, life-threatening emergency would be a bad idea. Further, the costs of a hospitalization for such a serious medical condition would often exceed even the highest deductibles, meaning that the full price of such a hospitalization wouldn't mean much to most patients. Prices are also made more relevant when they include information about the quality of healthcare being provided. Second, when prices are reported, they need to be accurate. That means they need to be a valid representation of what an individual patient could expect to pay for an entire healthcare service, not what the inflated billed charges, not what other insurers like Medicare pay, and not just what one small slice of a full episode of care costs. Despite the growing enthusiasm for price transparency, little is known about whether price information being reported to patients is relevant or accurate. To examine this area, my colleagues and I recently conducted a study in which we reviewed all state-based websites that publicly report healthcare prices to patients. In this study, which we published last year in the Journal of the American Medical Association, we found 62 such websites. We had unfortunately found that the information on these websites is probably irrelevant and inaccurate for many patients. Most prices were for inpatient care, for medical conditions or surgeries, which can often be unpredictable and emergent, and can carry a hefty price tag that most insured patients will never pay. Prices for outpatient services, which are often predictable, non-urgent, and subject to cost sharing, were reported much less often. For healthcare prices where quality can vary, information about quality was rarely reported alongside prices. Over 80% of the prices reported were billed charges, which are poor reflections of what a patient will actually be expected to pay. For services where a full episode of care often includes both facility and professional fees, for example, outpatient diagnostic procedures, 2/3 of price estimates only included facility fees. Finally, fewer than 1 in 10 price estimates were tailored to a patient's health insurance plan. So where does this national landscape leave Michigan? I think it leaves Michigan in an ideal position to take meaningful steps to improve price transparency. A number of states now have years of experience collecting price information and reporting it to the public, which can provide valuable lessons on what has worked, what hasn't, and what is right for Michigan. I recommend the following steps to seize this opportunity and make healthcare price transparency a reality in our state. Number one, pass legislation that requires reporting of prices for all healthcare providers and facilities in Michigan. Meaningful healthcare price transparency cannot be accomplished through voluntary reporting alone, and instead can only be realized through legislation that brings this information out into the marketplace. Senate Bill 627 represents a good first step towards this goal. Yet patients ultimately need access to prices in all places where healthcare is delivered, and this information is most useful to consumers when it is all located in a central place. States like Colorado, Maine, and Virginia have passed legislation in this area, which provides useful examples of how this can work. Number two, create an all-payer claims database for Michigan. Once prices are reported for Michigan healthcare providers and facilities, these data should be assembled into a single database that can support reporting efforts and analyses of healthcare costs. 16 states have passed legislation to create all-payer claims databases, and we can learn from their experiences. Senate Bill 333 would make Michigan the 17th state to join this movement, and I strongly urge its passage. Number three, create a website that is a one-stop shop for patients to access healthcare price information. In order for price information to be readily accessible for consumers, it should be available through a public website that reports prices for relevant services. These prices should represent what an individual patient would actually be expected to pay for an entire episode of care in all settings where they might receive that care. Common concerns are that data on payments for services rendered cannot be publicly reported, and that there is no way of tailoring a price estimate to an individual patient's cost sharing. However, states like Colorado, Virginia, and New Hampshire have demonstrated that these challenges can be overcome. In conclusion, as your committee considers how to advance healthcare price transparency in Michigan, I hope you'll take advantage of this unique opportunity to pursue common sense, market-oriented strategies. I look forward to working with you to learn from the experiences of other states and take steps to improve the affordability of healthcare for consumers in our state. Thank you.
Thank you, Doctor. I will check with other senators. Senator Hune.
Thank you, Mr. Chairman, and thank you, Doc, for your presentation. And just want to say thank you for putting a plug in for my Senate Bill 627.
You're welcome.
Senator Warren.
Thank you, Mr. Chair, and thank you for your presentation. You very briefly mentioned the issue of healthcare quality, and it's something as we look at trying to increase transparency in both cost and quality. I'm curious, you said you had the chance to analyze 62 different state-based websites. Did you see any examples where the combination of both cost and quality were merged together, not sort of in silo? I feel like we talk about these two things as being very important, but they're always in silos. They're never together.
Senator, that's a very good question, and it remains a tremendous challenge, is how do you align price information with quality information so that patients can gauge value? Frankly, much of the information that we found on state websites reports some sort of quality information. We had a very liberal definition of what constituted quality information. In many cases, that was available quality information for a particular hospital, but it may not have been pertinent to that particular healthcare service. And I think there's a lot of room for improvement in how we can merge quality information with price information, a lot more to understand about how we can make that information intelligible for consumers.
And one quick follow-up, if I may, Mr. Chair. And you mentioned a few states that we could look to as examples of sort of good websites for cost. Do you have any examples for us of ones that stuck out as good on the quality aspect that you would have us look at as a starting point?
So the question, as I understand it, is what states provide the best example of quality information? So in our particular study, we focused on the cost piece primarily, and we simply wanted to try to characterize again so that patients can gauge the value of services when quality information was reported. We did not, unfortunately, specifically look at the quality of the quality information reported.
Thank you. I have one question, and if Michigan were to pass a law creating a healthcare cost and quality database, some have asked why would we want to do that? And the answer seems very obvious to myself here working with this, and it's basically, I feel it's to empower the consumer to make a better choice. Mm-hmm. But more specific, what I want to talk to you about is, what do you think should be our purpose or goal when collecting and releasing this information to our residents / consumers? Mm-hmm. And how do we get to that little portion there of, releasing it, collecting it? Mm-hmm. Any words of wisdom?
Yeah, it's a great question, Mr. Chairman. I think it speaks to the fact that the states that have enacted or created all payer claims databases and then have initiated reporting efforts have had a variety of purposes in doing so. As a primary care physician, I most care about patients being able to get and afford the health care that they need. And the fact of it is that over 30% of adults in America now are enrolled in high-deductible health plans. We know from a variety of research that these patients are more likely to go without necessary care. And I think that all payer claims databases and then the reporting efforts they enable have the potential to provide consumers with actionable information about the relative cost for services at various places where they may try to get recommended or necessary care. And so I think one main purpose in those initiatives, from my perspective, in fact, the main purpose should be reporting useful information to consumers.
Well, we thank you very much, and we'll look forward to any communications that we might have as we proceed, okay? Thank you. Next, I would like to call Dr. Mark Fendrick up and Mark, anytime you want to start. You got the floor. If the red light's on, it's not stop, it's go.
Good afternoon. Thank you, Chairman Marleau, Ranking Member Warren, members of the committee. I'm Mark Fendrick, a professor of internal medicine and health management and policy at the University of Michigan, and I'm a member of the university's new Institute for Healthcare Policy and Innovation. I'm addressing you today not as a representative of the U of M, but as a primary care physician, a medical educator, and a public health professional. Mr. Chairman and members of the committee, I applaud you for holding this timely hearing on the important issue of adding value to our healthcare system. I completely agree with your assessment that price transparency and more engaged consumers are necessary elements to move us from a volume-based to a value-based system. This transformation involves not only how we pay for care, but importantly, how we involve consumers to seek care. I cannot agree more with my esteemed colleague, Dr. Kullgren, who made the recommendations that you pass Senate Bill 627 to require providers to report price information, pass Bill 333 to create the all-important all claims database for Michigan, and lastly, to encourage the creation of a consumer-friendly website that Michiganders can use to find timely information on cost and quality. That said, the crux of my remarks is to make clear to you that transparency is not enough to achieve our goals of quality improvement and cost containment. When cost and quality data are accurately determined and readily available, consumers still need better information regarding whether recommended treatments and procedures are clinically necessary. As we are all well aware, just because you could get a good price for something doesn't mean we should always buy it. There is a robust body of evidence documenting the overuse of medical services that produce no benefit and sometimes create harm. And according to the literature, these wasteful expenditures account for nearly 20% of our total healthcare expenditures. At the same time, life-saving services, such as immunizations, cancer screenings, and chronic disease treatments, are systematically underused. These are the services that Dr. Kullgren and I beg our patients to do, such as the critical treatments for asthma, diabetes, depression, and heart disease. As a result, several private and public initiatives are underway here in Michigan and across the country to help consumers understand the pros and cons of receiving certain medical services. Transparency doesn't do that. I've spent over 2 decades studying consumer engagement in the healthcare sector. Ideally, consumer cost-sharing levels would be set to encourage the clinically appropriate use of healthcare services. That means individual co-payments would be used to encourage consumers to think twice or thrice about those services they don't need, but at the same time create a complete removal of financial barriers to services that may be life savings. However, with few notable exceptions, health plans in Michigan, public and private, implement consumer cost sharing in what we call a one-size-fits-all way, in that beneficiaries are charged the same amount for every doctor visit, every diagnostic test, and every prescription drug. While I strongly support the notion of personal accountability, asking Michiganders to pay the same amount out of pocket for clinical services that vary tremendously in the amount of health that they produce seems very illogical to me. Does it make sense that my patients are asked to pay the same amount for a life-saving cancer drug as one that makes your toenail fungus go away or your hair grow back? Due to the lack of clinically nuanced incentives, my patients, Jeff's patients, consumers in Michigan, they use way too little high-value care and too much low-value care. Now, one possible solution to this blunt one-size-fits-all approach is based on the concept of clinical nuance. Better said, the fact that medical services differ in the health benefit they provide, even though we charge them the same amount. More than a decade ago, the private sector began to implement a concept that our multidisciplinary team developed here in Michigan, known as value-based insurance design, or VBID. The basic VBID premise calls for reducing financial barriers to evidence-based care and imposing disincentives to discourage the use of low-value care. It's common sense. When barriers to high-value treatments are reduced and access to low-value treatments is discouraged, we improve health. At the same time, we save money. Now, let me be clear, Mr. Chairman. I'm not asserting that price transparency, as Jeff talked about, or VBID programs that we have developed is the answer to our healthcare problems. But if we are going to be serious about bending the healthcare cost curve and improving quality and outcomes, as Senator Warren suggested, we must change the incentives for consumers as well as providers. So in addition to transparency, your committee is looking at a lot of really exciting initiatives, such as patient-centered medical homes and health information technology. If these initiatives provide providers incentives to recommend the right care, I think it's of equal importance that we incent our individuals with similar incentives as well. Now, knowing your experience as a businessman, Senator MARLEAU, I think you might find it incomprehensible to realize that my patient's insurance coverage does not offer easy access to the exact same services for which I am benchmarked and provided a financial incentive. Does it make any sense that I am offered a financial incentive to get my diabetic patients' eye examined when many of them have insurance plans that make it prohibitively expensive for them to visit an ophthalmologist or an optometrist? So the fact that we're providing incentives for the doctors and different incentives for the patients seems that we have to do something better to align the goals across the continuum of the people involved. I'm pleased to tell you that the intuitiveness of the VBID concept is driving momentum at a rapid pace in the private sector and is one of the few healthcare reform ideas with strong bipartisan political support, both in the U.S. Congress and in many legislatures such as this around the country. Hundreds of private self-insured employers, public organizations, not-for-profits, insurance plans have divined and tested VBID programs. I'm very proud to say that one of the most closely watched applications of VBID is its explicit inclusion in the Healthy Michigan Plan legislation, which in Section 105D1 requires plans to, quote, design and implement a copay structure that encourages the use of high-value services while discouraging low-value services. In addition, Section 105D5 requires plans to, quote, implement a pharmaceutical benefit that utilizes copays at appropriate levels allowable by CMS to encourage the use of high-value, low-cost prescriptions, end quote. So for the state of Michigan to stay at the cutting edge and remain a national leader in healthcare transformation, I believe that public and private plans in our state should be encouraged to do the following. First, set cost sharing based on clinical information such as diagnosis. Even though the clinical appropriateness for a specific service may vary widely among enrollees, cost sharing for any service is often the same price for everyone in the plan. For a diabetic to see an eye doctor, which needs to happen every year, currently has to have the same benefit of people without diabetes who only need to go to an eye doctor every 3, 4, 5 years. Number two, vary cost sharing for a particular service according to where the service is provided. The Commonwealth Fund recently estimated that nearly $200 billion in Medicare savings would accrue over 10 years if we were able to implement a value-based design that encourages beneficiaries to obtain care from high-performing providers, like those in our patient-centered medical homes here in Michigan. Last and most importantly, I would strongly encourage this legislature to really recommend that public and private plans implement differential cost sharing based on the clinical evidence, not just the price of clinical services. Just because things are cheap doesn't mean they should be cheap to my patients. I would much rather have those things that are potentially life-saving and health-producing be as low cost as possible for them. So to sum up, as this committee considers changes to transform our system from volume-based to value-based, it's my hope that you will take the common sense step to strongly encourage health plans to vary cost sharing based on the amount of health produced. Given the urgency to bend the cost curve nationally and here in Michigan, the legislature should abandon blunt instruments that reduce quality of care and instead support the use of clinically driven, not cost-driven programs that encourage the use of high-value services and deter access to low-value ones. Implementation of VBID programs can improve health, enhance personal responsibility, and lower the cost of care for the people here in Michigan. Thank you very much.
Thank you very much, Doctor. Any questions from any of the senators? I see none. I'm going to ask you the same question that I asked Jeffrey, Mark, what do you think should be our purpose or goal when collecting and releasing this information to the consumers of the state of Michigan?
Yeah, so as you might imagine, I agree very much with Jeff's comments with only one important caveat. Getting back to the crux of my remarks is that I have concerns that providing information on cost and quality and recognizing Senator Warren's concern about the lack of the ability to break down the silos of those two different areas, that a typical sophisticated or unsophisticated purchaser of healthcare would be able to use that as wisely as possible. First is this great dichotomy to be what things cost to the system, that either be the state as an employer or the state as funding Medicaid versus the beneficiary. So if you see a price that looks good for an intervention or a procedure, but then you realize that your health plan, through its narrow network or its coverage arrangement, makes it actually more or less expensive for you to go elsewhere, it's extremely important that we get it right away. Because I'm worried that once we let this genie out of the bottle, it'll be very hard to put her back in.
Thank you. Senator Warren?
Thank you, Mr. Chair, and thank you for your presentation. In the copy of the handout that we got, you give several examples of different companies and plans that are doing VBID type work around the nation, and you mentioned the Healthy Michigan Plan as being a place where, sort of as a state, putting our toe in the water on it. Do you have any examples that are Michigan-based that we could look at as we move forward, or are the examples that you have in here mostly from other states? Are those the good examples that we should look to as we continue our work on this topic?
So in this setting, of course, all the examples in Michigan are good examples. But I have to say we've had the good fortune to play outside of our own backyard early on before we brought, we thought, best practices to this committee and this legislature in the discussions around the Healthy Michigan Plan. I do think that the examples in the document in which I could speak to are ones that have been somewhat forward-thinking and driven, as many state legislatures are, around budgetary issues. One of the ones in there, in which we have a separate brief about, is the VBID implementation in the Connecticut state employees. And like Michigan, the state of Connecticut was confronted with a significant financial shortfall and needed to make some very critical decisions. And as opposed to many situations where the solution was just make the employees pay more, the state of Connecticut, with bipartisan support and multi-stakeholder support, realized that they could actually figure out that they should concentrate on how well they spend their money as opposed to how much they spend. And through this new healthy enhancement plan for the state employees, they did make it very, very easy for those beneficiaries to get the services that were felt to be evidence-based and high value. But there was a fair bit of accountability for those patients to do what's right. First, to get into the health enhancement plan, they had to see their physician as recommended by age and fill out a health risk assessment. And if they had certain chronic diseases, they got to see their providers and get certain services at lower cost compared to the other plan. However, if they did not go and do those recommended clinical services, they were held accountable either through higher premiums or actually asked to leave the plan. The very good news is that 97% of Connecticut state employees enrolled in the VBID plan. And now that it's 18 months in play, just about everyone's still in it and quite happy, and such that the state of Connecticut has expanded from state employees to municipal employees in Connecticut as well. We have talked about this plan with the Office of State Employer here in Michigan, and those discussions actually led to many of the interactions I've had here with this committee on the VBID process.
Sure, go right ahead.
It's one of those scary things where sometimes you're not supposed to ask the question that you don't know the answer to in advance. But as you were talking, I was thinking, we look at for years the fact that, especially in our Medicaid population, certain types of conditions, chronic conditions, are some of our biggest drivers. They're conditions that are expensive, and we always want to focus on ways that we can limit, help with early detection and compliance with treatment and medication for folks with heart disease and diabetes and things like that become very, very expensive over time. Do you have any of these programs been in existence long enough to see if you were encouraging, with cost sharing, more access to those kinds of medications and therapies for the the sort of high efficacy kind
Right.
of use, that you see results in terms of long-term cost impact to a state or to an employer?
So first off, because you're a quality person as well as a cost person, as a physician, I did not go to medical school to learn how to save you money. What I've learned as a physician, I want to make Michiganders healthier and also save you money. So the crux of value-based insurance design is always more health at any price. And we believe these clinically nuanced programs do that compared to these blunt instruments plans. So as I mentioned, value-based insurance design was a private sector-driven initiative, and the longest running and best studied VBID implementations all come from the private sector. We've done our own evaluations, but I'm happy to point you to a Health Affairs systematic review of 14 VBID programs, probably the best designed and best evaluated, which showed, not surprisingly, that as cost sharing was lowered for high-value services, particularly pharmaceuticals, people took their drugs more often. The next bit of good news, I think, for anybody, particularly a public servant, is costs went down for all the beneficiaries. So the public, or the beneficiaries, were very happy. So as the public paid less and the payer paid more, that's the also good news, that while there were not substantial savings in the first couple of years of these VBID plans, the employers and the public organizations that enrolled in these things were not paying any more than they were paying before, even though we had seen these process measures of drug adherence to move forward. In other studies that are longer, where we look to see, all right, taking these medications and going to see the doctors are good things, how does this impact on health and costs? And I think, as you'd expect, that the longer we follow these programs, the more we start seeing these savings in ER visits and hospitalizations that Jeff and I hope to do when we treat our patients with these chronic diseases. So one of the points that we try to make to esteemed organizations like this policy committee or private organizations is to not expect that these value-based insurance design incentive programs are going to lead to significant savings in the short term, because people will be buying more of the things that we want them to buy: preventive services, treatments for chronic diseases, and management and follow-up testing for these as well. So we strongly believe, and many organizations like the Congressional Budget Office believe, that the longer we put these programs in place, the longer people do the things that they were supposed to do, we will start to see these savings down the road, which is why we've been always kind of not very aggressive in promoting cost savings as we were in promoting health improvements, which I really think it'd be equal, if not more important, as we think about these changes in these programs.
And just one last quick one. So how old is the oldest sort of quality VBID program out there? How long is our data right now?
Right. So one VBID program is one VBID program. I think the most well-cited publication is a large group of employers in Florida did a diabetes VBID program, and at 4 years, they reported adherence increases that you'd expect, process measures in terms of the care of these diabetics improved, and cost savings for disease-specific spending in that program. A lot of us do computer simulations to project the impact of value-based insurance design over time, because most CEOs and some politicians are not willing to wait. And obviously, as we see more people engaging in these healthy behaviors, we do see these cost offsets increasing, and VBID tends to look better with a return on investment as time goes on. But I do want to say, to tie into Jeff's transparency remarks, I think as we take your earlier comment about breaking down silos, you're doing a lot of exciting things in the area of payment reform. You're doing a lot of exciting things in health information technology. You're doing lots of exciting things in wellness. And I've been concerned in other states seeing how the legislature has not had the foresight to bring these things together and understand there are tremendous synergies. I tend to talk about payment reform initiatives, as the Senator MARLEAU knows, as peanut butter, and consumer engagement initiatives as jelly. And I want all of you to remember the first magic, as the Senator just did, the first time you brought peanut butter and jelly together, and that when you align incentives for both patients and providers, you get much more than either you'll get from doing one alone.
One of the other things that I like to mention is that being realistic, I don't expect the cost to decrease, but I expect the increases to slow down. And that's, and maybe I'm naive, but that's what I'm hoping for, is to get these double-digit increases to start to slow down. And I think that that's what this is. I'm a firm believer that competition is what makes the world go round in other areas, and we need to take a look at it here. And I also make a comment the other day that you don't go in and sit down in a restaurant and order a meal without knowing the price of what you're ordering. And, you know, and it's just one of those things. So, again, it's one of those things that I think it's time, you know, and I'm hoping that we can get this process started. And I want to thank you for all of your help, and we can stay in touch as we go through this process. Thank you very kindly. Next committee, we will be taking up Senate Bill 704 and 904. These are Senator Hunes's bills. And Senator Hune, do you want to give us an explanation or on the, I think we have a substitute, don't we?
Sure. Thank you, Mr. Chairman. And last week, when I gave my comments, which I'm sure were so moving to our committee members, they were referencing the substitute that was before us. It's my understanding, Mr. Chairman, that we didn't adopt a substitute. But again, 5 of the main areas that we're addressing with the substitute in terms of compounding pharmacies, we address 5 main areas, including allowing Laura, the department, to immediately suspend a license with the situation of imminent risk to the public health, safety, or welfare. We also included language for accountability at the top, Mr. Chairman, and also having a pharmacist in charge. And also incorporate accurate record keeping, which has been an issue in the past, particularly with this situation dealing with fungal meningitis. We also require additional background checks, which were not included before 2008. We also reference the fingerprinting, which is already into effect, and additional robust and regular oversight, which was obviously an issue dealing with the Massachusetts compounding facility. And with that, Mr. Chairman, I can answer questions that the committee needs. I know we talked at length, and I don't want to filibuster.
Well, anyone have any further questions? Okay, I don't see any at this time. I'd like to ask the clerk to read in the cards.
Robin Norton and John Lizette are here in support of the bill and will answer questions if necessary.
Okay. Would you tell us who they're from?
Robin Norton from Lara and John Lizette from the AG's office.
Thank you.
Did you want them?
I don't see, is there any questions for either one of the people from, no, okay. Thank you. We appreciate their offer, but no questions at this time.
Eric Roth and Amanda Lick from the Michigan Pharmacists Association do not wish to speak and support the bill. Christine Shearer from the Michigan Association of Health Plans does not wish to speak and supports the bill. And Nicole Nystrom from CVS Caremark does not wish to speak and is in opposition to the bill.
Okay, thank you very much. At this time, Senator Hune moves to adopt the S2 substitute to Senate Bill 704. Would the clerk please call the roll?
Chairman Marleau.
Yes.
Senator Robertson.
Yes.
Senator Emmons. Senator Hune.
Yes.
Senator Jones.
Yes.
Senator Shoemaker. Senator Warren.
Yes.
Senator Johnson.
Yes.
Senator Ananick. Mr. Chair, there are 7 yeas. The motion is supported.
Thank you. Senator Ananick moves to report the SB 704, the S2, to the floor with recommendations that the bill pass. Would the clerk please call the roll?
Chairman Marleau.
Yes.
Senator Robertson.
Yes.
Senator Emmons. Senator Hune.
Yes.
Senator Jones.
Yes.
Senator Shoemaker. Senator Warren.
Yes.
Senator Johnson.
Yes.
Senator Ananick.
Yes.
Mr. Chair, there are 7 yeas. The motion is supported.
Okay. Senator Jones moves to recommend immediate effect for Senate Bill 704 with no objections. Immediate effect is granted. We now move on to Senate Bill 904. 904? Okay, sorry. Right. Senate Bill 904, At this time, Senator Robertson
I'll move it, Mr. Chair.
moves to report Senate Bill 904 to the floor with recommendations that the bill passes. Clerk, please call the roll.
Chairman Marlowe.
Yes.
Senator Robertson.
Yes.
Senator Emmons. Senator Hune. Senator Jones. Senator Shoemaker. Senator Warren. Senator Johnson. Senator Ananek. Mr. Chair, there are 7 yeas. The motion is supported.
Thank you. Senator Johnson moves to recommend immediate effect for Senate Bill 904. With no objections, immediate effect is granted. And at this time, we're going to go at ease for a moment, and we will then be coming back for the other bills, House Bill 5352 from Representative Lori. So, and we're just going to take a momentary at ease. The Senate Health Policy Committee is back in session. Thank you for the momentary. We're coming back to House Bill 5352.
5332.
I'm sorry, 5332. Thank you. I appreciate that. At this time, if there's any additional, there's no cards. I don't see. There's no card. So there's no. Is there anyone else that would like to speak on House Bill 5332? Not seeing anyone. And there's no cards to be read in. At this time, I'm going to ask Senator Robertson had some comments that he wanted to give us before we voted.
Yes. Thank you very much, Mr. Chair. I remember the testimony from last week, and I've read the analysis on the legislation, and everything about this legislation appears to be supportable. I noticed that the House vote was a unanimous one. But I also note that listed in the analysis provided to us is opposition from a significant number of folks from the deaf community. And I'm curious to know what their reasoning is for their opposition to the bill. And I'm going to be inquiring with them within the next few days on that. I will not, I'm going to pass on the vote today, but look forward to joining my colleagues in support of the bill on the Senate floor once my curiosity with regard to their position has been satisfied. Thank you very much, Mr. Chairman.
We appreciate your comments. At this time, I'll entertain a motion to pass House Bill 5352 to the floor with recommendations, and it is moved by Senator Hune. And would the clerk please call the roll?
Chairman Marlowe.
Yes.
Senator Robertson.
Pass.
Senator Emmons. Senator Hune. Senator Jones. Senator Shoemaker. Senator Warren. Senator Johnson. Senator Ananek. Mr. Chair, there are 6 yeas. The motion is supported.
Thank you. Senator Ananek moves for immediate effect for House Bill 5352 with no, I'm sorry, 5332 with no objections. Immediate effect has been given. With that being said, no other business is before us today. We are adjourned. And
Excuse absent.